Welcome to DoodleMed Insights.
Hello everyone. Today we are going to delve into the intriguing world of rheumatic fever and rheumatic heart disease. These conditions are intricately linked, and it's important to understand their background and etiology. Firstly, let's discuss rheumatic fever. This is a delayed autoimmune complication of a group of beta hemolytic streptococcal infection, typically stemming from tonsillopharyngitis. It's important to note that rheumatic fever and rheumatoid arthritis are two distinct diseases. Rheumatic fever presents with temporary arthritis, earning it the phrase, "licks joints but bites heart," as it can lead to permanent valvular damage and mild arthritis. On the other hand, rheumatoid arthritis licks heart but bites joints, causing mild myocarditis but leading to permanent severe arthritis. Moving on to the etiology of these conditions, we find that there are three key factors at play. Firstly, there is an environmental factor, with group A beta hemolytic streptococcal pharyngitis being a significant trigger. Secondly, genetic susceptibility plays a role, with around 3% of the population carrying HLA-DR2 and DR3 positive genes. Finally, autoimmunity is a crucial factor, with the production of autoantibodies, particularly those that cross-react with cardiac connective tissue due to antigenic mimicry. In the pathogenesis of rheumatic fever and rheumatic heart disease, an initial infection with group A beta hemolytic streptococcus triggers a complex immune response, particularly in individuals with HLA-DR2/3 genetic marker. About 2 weeks after the initial infection, the immune system, led by lymphocytes, initiates a response that can lead to rheumatic fever. Subsequent streptococcal infections strengthen this response, causing recurrent episodes of rheumatic fever and cumulative damage to the heart valves, ultimately resulting in rheumatic heart disease. This highlights the importance of early recognition and intervention to manage these conditions effectively. Let us start with acute rheumatic fever, a condition with diagnostic criteria established by the renowned Jones criteria. To meet the criteria, one must exhibit evidence of prior infection with group A beta hemolytic streptococcus, commonly known as Streptococcus pyogenes. This could be confirmed through various means, including anti-streptolysin O titer, anti-D-NASP antibodies, or a positive throat swab culture. In terms of symptoms, the Jones criteria outlines major and minor manifestations. Major criteria include migratory polyarthritis, carditis, inclusive of pericarditis with its hallmark signs such as friction rub, quiet heart sounds, and tachycardia. Subcutaneous nodules found on extensor surfaces. Erythema marginatum characterized by non-pruritic, tinea-like rings on the trunk and limbs, and Sydenham's chorea presenting as rapid, involuntary movements. Concurrently, minor criteria encompass fever, joint pain, elevated erythrocyte sedimentation rate, and prolonged PR segment on electrocardiogram. To make a diagnosis, one must have 2 major criteria or 1 major plus 2 minor. Transitioning to chronic rheumatic heart disease, where cardiac murmurs become the focal point, particularly in the left heart. We encounter entities like mitral stenosis, often accompanied by regurgitation, and aortic stenosis, which might present with or without regurgitation. Mitral stenosis, a hallmark of this disease spectrum, may exhibit what's termed as mitral facies, manifesting as a malar or butterfly rash over the cheeks and nose. The diagnosis is further supported by a mid-diastolic rumbling murmur, most pronounced at the apex during expiration and audible even in the axilla. Additionally, patients may suffer from pulmonary congestion and congestive cardiac failure due to right ventricular hypertrophy, leading to exertional dyspnea. Furthermore, as mitral stenosis progresses, patients face an increased risk of developing atrial fibrillation and infective endocarditis. As health guardians, we're exploring ways to prevent, treat, and manage these conditions to lessen their impact. First off, let's talk about stopping rheumatic fever before it starts. We recommend treating strep throat infection with penicillin V for about 10 days. If that's not available, amoxicillin or cephalexin can work too. Moving on to the next stage. If we suspect someone might have rheumatic fever, we bring them in for a closer look using what we call the Jones criteria to help us decide. When it comes to treating rheumatic fever, we have a few tricks up our sleeves. We start by getting rid of the strep bacteria with a single shot of benzyl penicillin G. For the achy joints, we use painkillers like NSAIDs or codeine. If someone's having trouble with movements, we might use carbamazepine or valproate. And for heart problems like carditis or heart failure, we have got a mix of medicines like angiotensin-converting enzyme inhibitors, beta blockers, and diuretics to help the heart work better. Now let's talk about preventing rheumatic fever from coming back. We recommend taking antibiotics for at least 10 years after the last time someone had rheumatic fever. Usually we give a shot of benzyl penicillin G once a month or penicillin V pills twice a day. If someone is allergic to penicillin, we switch to erythromycin pills. Lastly, if things get serious and the heart needs help, we might consider surgery to replace the mitral valve.
Thank you for your attention, and I hope you have gained valuable insight into this important topic.